Utah lawmakers tackled major healthcare policy changes this legislative session with bills affecting medical malpractice, prescription drug pricing, and hospital funding. Joining us to break down what happened during Utah's 45-day general session, we've got Francis Gibson, the president and CEO of the Utah Hospital Association, and Dave Gessel. He's the executive vice president at the Hospital Association. Guys, thanks for being with us.
Thank you for having us.
You guys seem to have recovered from the 45-day session. Everyone's feeling a little more refreshed.
We are. It's long. It's a short session, long days, but we're here.
All right, guys, let's jump into our first topic, which is the Medicaid hospital assessment. And Dave, I'll start with you. Can you just give us an explanation generally on what the legislature did regarding the impact of Medicaid funding for hospitals?
Thank you, Marty. Yes, one of the things that the legislature has done over time is to try to rationalize the funding for Medicaid. So we don't have a lot of years where there's a lot of funding increases or a lot of decreases. And that has led to a consensus set up where they work with the governor's office, Department of Health, providers, and the legislature to come up with a consensus number that they think will fund Medicaid. This year that was a 2% increase. That does not go directly to the hospitals, but it goes to the accountable care organizations that contract with the hospitals. And so that will be a benefit to the hospitals for sure, and to the patients that come to the hospitals.
So Francis, a 2% increase, let's start, I guess, with a question that maybe is just to make sure I get caught up to what
Sure.
you guys know about this. What was driving the need for that increase in the first place when it comes to the hospital assessment? What was like the motivation? Is it actually like a problem that needed to be solved, or was someone just saying we need to have a 2% increase?
So the 2% increase is just, it's almost like a cost of living increase, but it goes to the accountable care organizations who manage the care of people who are Medicaid recipients. And so there's a risk share involved there, and that these accountable care organizations say, I will manage your health care for X amount of dollars. And the hospitals work incongruent with the accountable care organizations. So that's the 2%. There is a hospital assessment that was assessed this year. And what that was, looking at the entire budget of what we spend on Medicaid. And there was obviously a shortage. There's always more demand than there is money that's provided. And so the assessment was wound up being an $18 million assessment charged to hospitals. And that hospitals pay the $18 million, and then we draw down from the feds a 2-to-1 match. And that happens every state throughout the country. But that's $18 million that the state of Utah does not have to pay. And that's $18 million that they can now use in other funding areas throughout the budget. And so the hospitals pay that $18 million this year. It was anticipated to be about a $37 million increase. We were able to negotiate that down to 18. It is a new fund. It is a new cost that's going to go to hospitals, but I think it's something that's warranted, and it's something hospitals can do.
Yeah, savings of about $19 million there. Dave, what if you're talking about an $18 million chunk that the state doesn't have to pay, but as Francis pointed out, the hospitals do? Help me understand what that means to hospitals then when suddenly, hey, there's $18 million of an increase in assessment.
Thank you. Overall, we can be assessed up to 6% under federal law, and this will take us essentially up there. So while this is an increase, we already have about $150 million hospital assessment. The one good thing about this is when working with the legislature, that increase to the hospitals won't happen in the next fiscal year. It starts July 1 of 2026 after the 2026 legislature. So we have a glide path to get there. But it's crucial funding for the hospitals. It allows us to get the kind of funding we need, because Medicaid traditionally has not been a very good payer compared to many of the other payers.
So let's shift topics then to SB 69. This dealt with the 340B drug program. And Francis, help us understand, like, what is that exactly? And what were the changes that were made with this bill?
Sure. About 30 years ago, the federal government worked with Big Pharma and just said, you will sell certain drugs at a discounted price to those hospitals or those health systems, whether it be rural health clinics, hospitals that serve the poor, the needy, Medicaid, uninsured. And in doing so, and the reason that program was put into place was to ensure that those services would still be available to be provided. There's this misnomer that those savings should go directly to the patient. Most of these patients receive free health care. And so going to the patient itself is not an option. What it was meant to do was to make sure that in rural Utah that these hospitals can stay open, or in the bigger urban areas, not just in Utah, but anywhere that participates in the 340B program, that those services can continue to be provided. And so those savings that the hospital systems are able to save by buying these discounted drugs are translated into the continued care for this particular population. And so what we have seen over the years is that pharma has continued to increase the amount of exclusions. So drugs will be excluded from this program. We're talking about drugs for COPD, diabetes, hypertension, heart disease, lots of different drugs. And we saw just a continued increase in that. One of the things that this bill does is that continues to allow hospitals to have contract pharmacies. So if you can think of a hospital that may be here in Salt Lake City, and someone is coming in to get care at the University of Utah or at IMED, what we will do is we'll send a prescription to a contract pharmacy that may be across the city in West Valley, or maybe a little bit north, or maybe in Utah County. And by being able to have a contract pharmacy be able to provide the drugs for this person, it allows that patient to get that medication closer to home. And so what this bill does is allows contract pharmacies to still be in place. Whereas Big Pharma would say, we're going to reduce that down to just a smaller amount of pharmacies. And the amount of people and the amount of effort it would take to get your drugs, it doesn't make sense. It is a burden on a population that's barely able to get care, and now to add that burden to get medication would be difficult. And so really what this bill does, it allows the contract pharmacy piece to stay in place.
Dave, what implementation challenges do you foresee on this one, and how is the Hospital Association helping members prepare to meet those challenges?
Thank you. First, I'd like to say this is really a historic bill. This was a really big team effort from a lot of folks led by Francis and others. That's just remarkable we were able to get it done. Because this is a big debate across the country. We now are one of 8 or 9 states that have passed it. The implementation shouldn't be very difficult because the language is quite a short bill and very direct to the Big Pharma. But unfortunately, historically, in many other states that similar bills have passed, they've chosen to sue to try to hold back the law. And we don't know if that will happen or not, but that will definitely, it will go in a different court, if you will, but that'll take some time to get through if they sue. But we're confident we can win because virtually every other state they've sued in, the hospitals and the providers have won.
And we look at the magnitude of this. This is roughly, this program, 340B program, saves Utah hospitals nearly $200 million a year collectively. That's also the federally qualified health clinics in the small rural areas, which may only have a nurse practitioner or a physician's assistant serving these small communities of 500 to 1,000 people. We have those in Utah. It's the rural hospitals that are able to keep their doors open, and you know, you're talking about $2 to $3 million savings a year in which they're able to purchase these drugs at a discount price, to the University of Utah, which may be $70 million, or Intermountain, which is another big chunk. And so collectively in aggregate, it's easy to see this is nearly a $200 million savings to continue to provide care for those most vulnerable in the state of Utah.
Kind of issue that if it goes the other way, it really impacts hospitals generally, but it sounds like in particular in rural Utah could have a pretty significant impact.
Absolutely.
Yeah. I want to turn to our final issue from the session that we want to get into today. This relates to medical malpractice. HB 503 was sponsored by Katie Hall, and it aimed to reform medical malpractice laws. Let's talk about the key provisions in the medical malpractice bill. What are those key provisions, Dave? You were the one who really locked in on this one during this session, so tell us a bit about the bill.
Well, there were actually 3 bills, one brought by the trial bar, the plaintiff's lawyers, and 2 from the provider side. We haven't had these debates for many years, and it just happened to happen this session. But House Bill 503 is very beneficial to hospitals and physicians and other providers. Its main points are really an interesting thing of, it basically says that doctors' assets or individual providers' assets can't be taken in a lawsuit as long as they maintain $1 million worth of malpractice insurance, which is kind of the standard now. And that's a huge emotional, I think, lift off the doctors who are always worried, you know, I make one mistake, can I lose everything I've worked for? That was a really big piece of this. There's some other pieces that improves the pre-litigation panel. It also it gives more authority that they can still choose to do it for judges to give defense folks, hospitals and doctors, attorney's fees from the plaintiff's side if it's not a meritorious case. I'd say the last thing it really did was dealing with what's called billed versus paid. We all know that when we go to a hospital or physician or whatever, we get a bill that says a lot more than we actually pay or our insurance company pays. That will change now. Only what can be put into the court is what was actually paid and not the higher amount as potential damages. So it was a good team effort there too, and I think it will benefit Utah patients and Utah providers.
How does legislation compare to what we see in other states? Does this put Utah more in line with the rest of the country? Are we on the leading edge of something, or are we still trying to play catch up somewhere?
Great question. We're in the top quarter, let's say, of laws that have passed to help on the provider side for hospitals and physicians. This will probably take us up a few more, but we have been blessed with a legislature over the years, and again this year, that really understand the impact that this can have on organizations and individual providers, and they try to help where they can, and this is one of the years they did that.
But looking at the rates of malpractice insurance, when you have things like this in place, it really helps keep the malpractice insurance down. Physicians are up against reduced reimbursements every year, and while costs are going up, just as hospitals are as well. And so I think a bill like this helps reduce the cost of providing health care, and thus helping the state of Utah keep health care in general lower.
Yeah. Dave, how many years does this make for you? How many sessions have you worked up on the Hill?
Well, for the Hospital Association, 31 years.
31 years. Give us some kind of perspective then. How does this one rank, or what stands out about this session compared to the other 30?
Well, this was a great session for hospitals, particularly with the 340B program. I would rank this as a top 5 session. But it was challenging in that there was a lot more, I would say, legislation this year specifically targeting hospitals in the past. Some other bills we haven't talked about that we were able to stop. Some we'll have to implement. But they're all unique, and this one was unique as well.
Mr. Majority Leader Emeritus, you've been up there a number of years yourself. You want to give us sort of your take on this session?
Yeah.
How things went overall for your efforts as the Hospital Association?
You know, I think things were well. We have, historically, education has always been the biggest issue that legislators, and even myself when I served for a long time, that was always a big concern. But when we look at the rising cost of healthcare, and we look at Medicaid as being now one of the biggest, or the biggest budget item, and what that looks like, and so rightfully so, legislators want to learn more. I am appreciative of those legislators who want to reach out and say, hey, what's your role in this? And are at least willing to listen and let us kind of paint a picture from our view. And everyone has a different view. But this legislative session had a lot of bills geared toward healthcare. And what does that look like? And I suspect moving forward that will happen again. Very busy session. I'm appreciative of the results of the things that came out. We had some wins, had some losses, but I think overall, our legislature does a good job in Utah. It's it's one of the shortest sessions in the country. They balance the budget every year, which is not easy. And there's never a shortage of demands for people that are looking for additional funds. And overall, I think it was a good session.
Yeah. Always important to keep your members involved when you're an association and you're up on the Hill. You did a lot this session. You both were working hard up there. We pulled Francis off because you were speaking directly to your membership, giving them updates each week throughout the session. And now a recap like this, I presume that what you want is your members to know that this is a team effort and their participation is helpful.
Oh, absolutely. I think that Dave and I are there full time, and we were able to get some different members, depending on what the bill was, to come up and testify and kind of give their firsthand experience. I would say this to our members who are watching. Anytime you get a chance to tell what's happening and how this bill will affect your day-to-day life, or how it will affect the patients that we serve, goes a lot further than either Dave or I. And so continued support, looking to continue to reach out, and I encourage you, get legislators to come tour your hospitals and let them see what you do. Let them hear from your caregivers that work with you.
I would just add that we appreciate the involvement of our board, of the system lobbyists, of the CEOs, because what I've learned in those 31 years is that when we're together, when we agree and we work together, we're a very powerful and formidable industry in this state. When we split, which can happen at times, we get hurt, and that's just been pretty much true the whole time I've been there.
United we stand, divided we conquer. Dave Gessel, Francis Gibson, both from the Hospital Association, thanks so much for your work during the session and for giving us a recap.
Thank you.
Can I give a shout out to
You
you?
can give a shout out, yeah, if you'd like.
This is our first year.
Yeah.
Northbound Strategies. It's been awesome. Looking forward to a continued relationship as we move forward. Look for more updates on different topics that affect hospitals, from workforce to you name it. There'll be lots of different things that we'll put out. And so I appreciate you coming up this year and look forward to seeing what we can produce moving forward.
Great story to tell, and we will work on telling that story for you guys at the Hospital Association and the hospitals who are members as we go forward.